Okay, good evening. Hello, everyone. It's 12th of July 23. I'm Sharif Awad, consultant bariatric surgeon from Derby and educational lead for BOMSS. Welcome to another journal club. We're resuming after the successful ASM in Birmingham last month. The hosts for this evening are the MDT from Swansea. So we have Andrew Beamish and Scott Kaplan, two consultant surgical colleagues. The Journal Club is sponsored by Apollo, so thanks very much for the support. We will be recording the Journal Club and we'll send a link of the recording in August, along with all the other recordings of the educational activities for earlier in the year. There's going to be two papers presented. If I can ask the audience to please post your questions via the Q&A button, and we're going to do things slightly differently. So the two papers will be presented by the team at Swansea, and then we'll have the Q&A right at the end. So without further ado, I'll hand over to Andy. Thank you very much for hosting tonight, Andy.
Mute. Thank you very much, Sharif. It's a pleasure to be back again on behalf of Swansea, the Welsh Institute of Metabolic and Obesity Surgery. It's actually been about 18 months since we last hosted, which has flown by. We've been very busy. I know lots of people out there have as well. So it's our delight to be back to host the Journal Club. So as Sharif said, we're going to do things very slightly differently. A similar setup with two papers and two presenters. But this time we're going to run straight through, and there's a theme, two themes in fact, that we're going to concentrate on. So welcome on behalf of Swansea, and we're going to move through both papers onto the learning points and have a bit of time at the end as usual for a panel discussion. So our themes today were extremes of the lifespan, and secondly, assessing evidence and how we assess evidence, which I think is something that we do quite often in journal clubs between us very often, but it's really important to assess evidence with an open mind. So that's what we're going to concentrate on today. We were actually going to talk about this paper, but unfortunately we were pipped to the post a couple of months ago by the Sunderland team. So instead we've gone even further back through adolescence into pregnancy, so even more extreme. So when we come to thinking about evidence, the days of walking into a place looking for evidence like this fantastic library, they're pretty much gone. You know, these libraries exist, but it's not where we get our information from. Instead of the benefits of this place, which after all has four walls, and if it's not in there, then you can't find it. Instead, today, we're more likely to find things in these kind of places where you enter at your own risk down into the rabbit's warren. And if you find what you're looking for, then you've got to start to assess it. You know, where does it sit on the pyramid of evidence? Which level of evidence is it? Is it right down at the bottom, expert opinion, or has it actually climbed up that ladder towards the pinnacle, which is a meta-analysis of randomized controlled trials? And so we're going to talk a little bit about two papers, one of which is a randomized trial, and one of which is a little bit further down the pyramid, retrospective cohort study. So this is the first paper that I'll talk about before handing over to Scott Kaplan. So the title was Food Tolerance and Nutritional Risk After Sleeve Gastrectomy and Roux-en-Y Gastric Bypass in Elderly Patients with Severe Obesity. And it's a prospective randomized trial. So as we mentioned just in that pyramid then, it is a randomized trial. You know, that's level 1 evidence. It's up at the pinnacle of that pyramid that we know and love. It was an RCT of nutritional outcomes specifically after sleeve versus bypass in the elderly. So the age group was more than 65 years. That's what's classified as elderly. And there were 36 participants. They reported that there was no difference in food tolerance, but there was a nutritional risk that was greater after gastric bypass by comparison to sleeve gastrectomy. So going through the papers, what I tend to do when I assess evidence, which is our second theme, you know, how to assess studies. We know that the study type. So I tend to go through the abstract and get an overview for things and then move on to the methods and work out whether they've done things in a way that's reliable and a way that's going to allow us to gain any information that's useful from the rest of the paper. So this abstract was reasonably nicely put together. You know, they've listed out the rationale for the study. They've talked about the age group and the relevance of a nutritional risk. They've kept it concise. You know, that's probably because of the instructions to authors. You know, they're very clear these days of what you need to include and how many words you can use to talk about in it. And they presented the findings. It's very clear what they found. However, it doesn't really clarify that the whole thing is based on secondary analysis within a randomized trial. And it's very easy as a result to assume that the trial was designed for this particular analysis, for this research question, when in actual fact, this is a secondary analysis of a trial that was examining a whole different question. So we look at the methods then. There are definitely some strengths. You know, this is a randomized trial, so they've randomized their participants. There's a very clear question, and it's outlined in the abstract right up front. It's even in the title. There's a relevant population for the study question, and they've used a validated questionnaire that looks at alimentation scores. They've used this BIA, which is a little bit in vogue these days. It's been around for a long time, but it's a method of assessing body composition. And they've used very standardized procedures. They've used simple, relevant, and uncomplicated statistical analyses, which I think is a very good strength. It's very easy to do complicated things when you don't need them. There are some limitations that the authors have acknowledged. So they said that there's no baseline nutritional measures. They didn't have a dental assessment, very important in the elderly when you're looking at, you know, nutritional scores and looking at their alimentation. There's very short follow-up, which they acknowledge, and there's a very thin literature for this particular application of bioimpedance analysis. But there are also quite a lot of limitations that they haven't mentioned, haven't been brought to the reader's attention, and definitely pose a risk to the quality of the study. There's small numbers, you know, that's very clear from the outset. They haven't really addressed it. There's no sign whatsoever in this, or indeed the original randomized trial paper, of a power calculation and how they came to the number. They didn't say it's a secondary analysis, as you've said, and the inclusion criteria are not very clear from this paper, although they do touch on them in the other paper. There were 20% of the patients, or the participants rather, dropped out, and it's not very clear exactly how that happened from this paper. And it's 2023, well, actually it was 2017 when they were doing this, and still people are using sealed envelopes to randomize. I mean, we've got to do better than that. You can't use envelopes, which is so vulnerable to bias and to cheating. It's just, you know, we've got computers in front of every single one of us, and it's unacceptable to do that these days. More limitations, you know, additional interventions were actually performed. So some of these patients, whenever needed, so when they decided, they chose some patients to try and improve the primary outcome. You know, if that's not bias, I'm not sure what is. So they sent some people to dentists and said, they can't eat very well, can you help them? And so I think that's something that clearly needed to be addressed in advance and measured in advance in the groups. They used self-reported data. There's only 3 days of intake recorded. So you can see that when you look beneath the surface, there's quite a lot of things that really pose a risk to the quality of the study. So often it's at this point where I will say, actually, stop, I'm out. It's probably not particularly beneficial for me to read the results, to read the discussion, because the quality of how we're going to interpret this study is probably just not there. So for the purposes of assessing the paper and how we would do it, if the quality was a little bit better, then moving on to the results, you can see that actually there's another learning point here, that the groups were unbalanced, but you can see that there's a p-value column on here. Anybody publishing a randomized trial in a good quality journal will be told by their reviewers and their editors, this should not have a p-value column. And that's because if you've got confidence in the randomization process, and if your power is appropriate for the study, then the randomization process takes care of balancing the groups. And anything that's in that p-value column that's statistically significant is down to chance by definition. So it's defunct, it's not necessary. And it is a little bit worrying to see in a journal, because then you think, well, do the reviewers, are they familiar with assessing randomized trials? Are the editors, you know, does the journal regularly publish randomized trials? And the answer is, you know, maybe not. And that's not the fault of the journal, because, you know, there has to be a spectrum of journals, but it's an important thing to think about when you're reading these things. The groups were unbalanced. So they've given us the p-values, so we should look at them, and they were unbalanced on the preoperative BMI. You can see that from the beginning. So there's definitely an inkling that there was a very high risk of type 2 error, which means that the number of patient studies wasn't sufficient to be able to answer the research questions. More in the results. So the weight outcomes they did report some weight outcomes, but they're of secondary or very limited relevance to this particular study, which is mostly about nutrition. And they're probably unreliable, as we've established that our confidence in the power of the study or its ability to answer the question based on the numbers is pretty low confidence. The headlines for nutrition, they found that there were comparable energy intakes and food tolerance between the different procedures in the elderly, and there was a lower phase angle. So that's the measure that they used and reported regarding BIA, bioimpedance analysis, which we'll touch on in just a second. And satisfaction among patients was comparable between the groups. So we're just going to pause for a quick learning point about bioimpedance analysis, and the phase angle. So this is very surface level. It's not intended to be complex statistical knowledge that I'm going to give you, but bioimpedance is a measure of body composition. It's a method of measuring body composition. And this chart down here just shows you how it's actually measured. They take the measures that are of impedance, of reactance, and the frequency, and that's what you use to work out what the phase angle is. And the importance of the phase angle is that it's got a significant association with muscle strength and engagement in physical activity. So if you're physically active, you can improve your phase angle. Something to take away. Then the discussion. So there were 7 short paragraphs. It's not very detailed. It doesn't really go beneath the surface at all. And it is missing out all those limitations that we highlighted a little bit earlier. There's very little discussion of the relevance of the findings to actual real world clinical outcomes, which is surely the whole point when you're talking about a nutritional paper. How's the nutrition going to affect patients? What's the relevance? So in their conclusions, they said that there is similar food tolerance after sleeve versus bypass in the elderly, but there's worse nutritional risk after a bypass. And as this chap, Salt Bay, who you may remember from a good while ago, would say, maybe take things with a pinch of salt, because are the conclusions supported by the data? And I'd argue that they aren't really in this case. So that's it for paper 1. And we're going to draw a direct comparison with another paper that I'll hand over to Scott Kaplan to take over with.
Good evening, everyone. Thanks for joining us for this journal club. So I'm going to be talking about the second paper on the list, which is going to the other extreme of life. We're looking at pregnancy and neonatal outcome after bariatric surgery. We know that approximately half of the patients we operate, or the women we operate on, are in the appropriate age for reproduction. And so it's obviously something we need to take seriously. And so we've looked at this paper to see how effective it is at helping us with our care of patients as they undergo pregnancy. This is not a randomized controlled trial. This is a retrospective cohort study. Do you want to move on, Andy? A retrospective cohort study. So on the pyramid that Andy put up earlier, it's a couple of steps down in terms of strength of evidence. And what they did was they looked at a large number of patients who had their babies, and a proportion of those had undergone a telephone nutritional management program in the period of pregnancy. It's a Kaiser Permanente group in America, and they had various programs. And they compared that with patients who hadn't undergone the telephone nutritional management program. And the headline outcome is that they found that patients who had undergone the telephone nutritional management program had improved perinatal outcomes and was beneficial to the babies. So if we move on, Andy. The abstract of this paper is very clear. It tells you exactly what the study is and what they're trying to do, and it summarizes the methods nicely and then presents their basic results and their conclusion. It reads well, and they write very clearly in this paper, but there's some other strengths of this abstract. It doesn't talk about causation. They just look at the association between the nutritional program and the outcomes. They tell you exactly what they're looking at in their questions, and they make it clear within the abstract exactly what the paper's all about. So it's a good start in terms of the paper. The methods, what they did was identified more than 15,000 pregnancies of patients who had undergone bariatric surgery over, I think, a 10-year period in America. The patients in the Kaiser Permanente have fairly extensive electronic health records, and they were able to access lots of data about it. The nutritional program is staffed 24/7 by nurses and has dietitians 5 days a week for 8 hours a day, giving advice. They monitor the patients and see as appropriate, but a minimum of once each trimester. They modify medications as appropriate, and they arrange for intensive monitoring where appropriate for reasons of hypertension and medication modification, diabetes and medication modification, or factors such as nutritional difficulties. It's all very clearly explained, and they describe exactly the process very clearly in the paper. They say what they're after achieving from the paper, they define their outcomes, and they measure those clearly. Now, this is a retrospective cohort study, so it's not as clear as a randomized control study how you can match the groups. So they use a statistical tool called propensity score matching. So what they do well in this paper is they take the available data and they do what you can with it to get the best results from it. So propensity score matching, we'll just have a quick talk about that if you want to jump forward, Andy. It's a way to simulate experiential study in an observational data set in order to try and eke out causal effects. It's quite an advanced statistical technique. The more I looked into it, the more advanced I realized it was. So I'm not going to sort of try and explain it in detail, but effectively what you do is you identify the factors that you think may lead to differences and biases between the groups, and they make it clear what those factors are, and they list those factors in the paper. And then you use statistical analysis and clever maths to create a score that the likelihood of each patient is to have followed the treatment arm, in this case, the nutritional score, nutritional support. And they then take the patients from one group, the smaller group, which in this case is the control group, and you match those propensity scores against the studied group. You can do this in various different ways, and in the simplest way, you match all the patients in the control group up until you have filled all the matching with the closest matching propensity scores, and then you discard the subsequent patients from the study. So you have all the patients in the intervention group that have a propensity score. You match them against the comparison patients via propensity score, and then you drop patients who you can't match because the scores don't match, or the superfluous patients. Now, I don't know if that's the exact detail of what they used in this paper, because there are more fancy techniques that I've come across where you can actually include all the patients in the study and make allowances on the propensity score. They don't talk about whether they've used the exact details of the propensity scoring technique they've used. But this is a well-recognized technique to allow observational data to be analyzed to estimate a causal effect, and they've used it well. So it's given them a large data set, and they've manipulated it well. Fine. Can we go on to the next slide, Andy? So there are limitations within their method, and they acknowledge these limitations. It's not a randomized, it's a retrospective study. It does come from one unit, which is a strength in one, or one provider, which is a strength in one sense because they have access to lots and lots of data, but it needs to prove that it's applicable in a wider world. They have multiple data sources from the Kaiser Permanente group, which again, you can also consider a strength. There are some weaknesses in terms of some missing data. They couldn't clarify, or they could only clarify for a small proportion of the patients what operation they'd had. So they can't make any comparisons between different operations, although they do an exploratory analysis on that, but acknowledge it's an exploratory analysis. They also mention that their confounding factors, which they list, may not be a complete list of confounding factors. And that is one of the weaknesses of propensity score matching, in that if you don't include factors in your analysis that may lead to biases between the groups, then the groups won't be evened out by the propensity score matching. And that particularly comes into, they're comparing patients who opted into a dietetic program versus those who didn't opt in, and the motivations as to why they opted in or didn't opt in are very, very difficult to elucidate. So in the results, they put loads of data in the results. As you can see, they have put a p-value, which is appropriate in this case because it's not a randomization. So they're comparing the two groups, and the groups weren't perfectly matched at the end of the day. You can see that the pre-pregnancy BMI, the time of input, the presence or how they are insured. So the patients with Medicare insurance were less likely to undertake the nutritional program versus those who had other forms of insurance. So the matching is far from perfect, but they give a wealth of details, and they then take that onto their results to show you what the difference is that they can talk about as being relevant. So the bottom line is that following the telephone program, there is a decreased risk of preterm birth, preeclampsia, and intensive care admission level 2 or level 3. The ARR is the adjusted relative risk because it's propensity score matching. So it's not a true relative risk, it's an adjusted relative risk. They didn't show any difference in C-section rates, birth weight, either low or high birth weight, or in gestational diabetes. So overall, it was a good paper. They discuss the study well. They go into all the details. They have some criticism of themselves in terms of the limitations of their statistical technique. They concentrate very much on what is clinically relevant. They acknowledge that they haven't got complete data, but they have got, to be fair, a very large data set. And they explore what could be improved about the paper. So I think it's a level 2, it's a retrospective cohort study, but it is very well done. The statistical analysis is good, it's clearly written, and their conclusions are clearly delineated. Overall, they would recommend participation in a nutritional screening model during pregnancy, and they think this improves perinatal outcomes. Do we think that this paper is supportive of that? I think quite clearly it is. The numbers are big and the results are good. So Salt Bay doesn't need to come into this this paper. So
Thanks, Scott.
To you, Andy.
Thank you very much. So that brings us back to some learning points about comparing these two papers head to head. And I've just brought back to this slide that we saw earlier, where we talk about the levels of evidence. And it's very easy to look at this and say, well, obviously right at the top, if we've got a meta-analysis of randomized controlled trials, it's the pinnacle. It's much better than anything below it. We should believe it. We should trust it. And if we put the papers that we've just discussed on that chart, you can see paper 1 obviously falls higher than paper 2. But is this appropriate? And the reality, as you've probably gleaned from our discussion today and the learning points that we're trying to get across, in this journal club is that actually paper one's conclusions are not supported by the data that they presented because of the methods that they've used. Whereas paper two, although it's a lower level of evidence, it's a much higher quality of evidence. And therefore, we're much more likely to use those data to inform our practice. So paper two stays on the chart, and paper one, I'm afraid, goes straight in the waste paper basket. So peer review is not proof of quality. It's useful, and it's what we've got. And there have been loads and loads of different ways of trying to say, what could we do better? Should we put pre-proofs on everything so the community can criticize, can praise, can find out and eke out what's quality and what's not? You know, there's all kinds of predatory journals who will publish anything you'll throw at them as long as it's accompanied by a check. And it's really difficult, especially at the beginning of a research career, to tease out what is quality in terms of a journal, where you should put your research, and how to assess what is good quality journal, good quality research published by other researchers. So it's really important to keep an open mind, and a little bit of skepticism, I think, is really healthy. Good science is really difficult to deliver, and it's expensive as well. So it's really important to be able to identify where the strengths are, where the limitations are, and how they affect the quality of what you're reading. Because at the end of the day, what we're trying to do is take data from more than just the patients we deal with to influence how we deal with the patients in front of us. So some initial clues that we can take away, you know, there are so many journals exist, and this is actually a reasonable journal, in Taiwan, the Journal of Fuzzy Systems, genuinely a real thing, not relevant to us, but ask yourself, have you heard of the journal? You know, is it relevant to your field? The big journals you will have heard of. You know, we're not all going to turn around tomorrow and publish in New England Journal of Medicine, but you know that if you're reading something in New England Journal of Medicine, it's been heavily scrutinized and it's probably really good quality. You know, you can find flaws, but it's probably pretty damn good. The impact factor, you know, if you look at journals with an impact factor at the peak of our field, you're looking in the 30s, 40s, 50s. In surgery, an impact factor of more than 15, there are only 2 journals with that. So really important to look at it, but it's not the be all and end all. You still get bad research and not very good quality things with many flaws in high impact factor journals. If you don't know the journal, if you're not sure of its impact factor, you can find these things from the publisher, and you can glean a little bit about who's publishing the journal. You know, there are big names in there, Wolters Kluwer, Elsevier, all these publishers people will have heard of. You know, if they're publishing titles like The Lancet, then some of the other journals might not be as good quality, but there's going to be a baseline level of quality that people expect as a publisher. You can also look at the institution. You know, where's this paper come from? We heard about the Kaiser Permanente, and Mr. Kaplan clearly outlined all those things that make Kaiser Permanente have a lot more chance of delivering high quality research than most units that we're involved with, because they're really well resourced. They've got a huge volume of patients. And so a single institution paper from Kaiser Permanente is going to be much higher quality than a single institution paper from our unit, YMOS. And that's okay, you know, but it gives you a clue as to what you're looking at. And the research group, you know, the Kaiser Permanente group, again, you might recognize names in those research units after you've started reading multiple papers. And use a system when you go through. So my rough and ready system that we went through today was look at the abstract, heavily scrutinize the methods before anything else, get a feel for whether it's relevant to you from the abstract and how it's done. But the methods is what's going to tell you, can I trust this? Have they done something that I could replicate with the right resources? Is it clear how they did it? In the second paper, it really was. And Scott clearly outlined they've been so explicit with the limitations, with the methods, with how they've done it. You know, those things you can see from the methods without even looking any further. And then, and only then, do I go on to look at the results and feed into the discussion, and how hopefully it gives some rich food for thought about how the team producing the research feel that it's relevant to the reader. And that's the purpose of research, is to communicate to you as the reader. Checklists are available. You know, you can get really high quality things. So the Centre for Evidence-Based Medicine, we're fortunate enough to have that in the UK. and it's a world leading unit, giving loads and loads of resources about how to read papers, how to scrutinize them, checklists if you're producing research about what you should include, and making sure that when you design studies, small or big or great, it's really important to use checklists and make sure that you're doing the things that are going to stop you from making mistakes. The moth is always drawn to the flame, and when we see a title that sounds like it's high up on the evidence-based pyramid, it sounds like this must be good because it's a randomized trial. But as we've shown hopefully today, the quality of the study is not always the same as where it lies on the pyramid of evidence. And so it's really important to have your own strategy when you read a paper to be able to know, am I getting useful information, or actually is this something that's going to mislead me and potentially put my patients at risk if I follow it? So that's us done for the presentation part, and now we can go on to fielding some questions, hopefully.
Thank you very much, Andy and Scott. Really, really fantastic presentation this evening, just to take us through the methods and a lovely demonstration of a good paper versus one that could be improved. So let's have a look if any questions have come in through the Q&A. So one from Katie. Yes, so she's just basically iterated what I've said, that brilliant journal club with lots and lots of learning points. So I agree completely. And I think we're going to be sending out the recording of the journal club next month, along with the others, as I've said earlier, and definitely the link to this month's journal club. I will be sending it to all our trainees who are doing surgery at the minute in Derby, because I think there's lots and lots to learn from there. Now, in terms of the two papers then, were there any applicable learning points at all from the sleeve versus bypass nutritional risk paper that you would take, Andy? Or did you literally just discard it and not bother?
I mean, I am quite ruthless, actually. I think if you can't justify the methods and you can't either reproduce them or rely upon them, then I think anything else beyond that, I think it's important to be ruthless, actually. And I think what it can do, though, is stimulate thought about how to answer the same question in a better way. You know, that it's a really important question, but we've got to find a better way to answer it.
So just delving into your unit and your practice, what proportion of patients you operate on are above 65 years of age? Do you have many, or is it literally just a handful?
It's a handful. It's a handful. We do have them. And at the moment, actually, they're people who have been hanging around in the system for a while with some things outstanding, and they've crossed the threshold just about. And we don't have a hard and fast rule about, you know, you hit that birthday and you're done. I think that's really important because age is a number, but it's physiology that matters more. And, you know, you might have a 50-year-old who, for the reasons you might think would apply to a 70-year-old, they're not eligible, then it's not in their interest. So we do, but not very often.
And do you have, so you mentioned the really important point about looking at dentition, of course, and hopefully the dietitians in most services would assess that and cover that with patients. But is there anything else specific to that age group that you would encourage people to look at or alter the pathway slightly so that, you know, you are doing the appropriate assessments for the over 65s?
Yeah, that's a good question. I think dentition is really good, you know, pun intended, food for thought, because it's the kind of thing that our normal patient group, we don't tend to think about much. But actually, taking aside the age thing, again, just putting that out as a number, there's actually quite poor dentition in the young as well, in populations that we serve that have quite a lot of deprivation. So it's probably something that we should look into a lot more across the whole age range. And then in terms of the elderly, you know, I off the top of my head, it's difficult to come up with something straightforward, but I think it should be a springboard for us to think about how is this received by the patient who is outside of who we normally communicate with, because you do get into a rhythm, you know, you get into habits of how you communicate to people, and you know, people can't necessarily use the same technology, they can't always, you know, attend virtual appointments that we're using more often. You know, we're actually quite interested in using technological solutions to follow up and to complement what we do. And we really have to consider, you know, the whole age range, you know, young to old, when we do make changes like that.
We've had a couple of patients as part of our service, 3 or 4 actually, that come to mind who've had poor dentition, which for some reason has got much worse, significantly much worse after they've had their weight loss operation. No sort of causal effect being mentioned here, but they have massively struggled to be able to chew food post-op, nutritional compromise, and trying to get them. And of course, Derby, I'm sure, is very similar to your region. So we serve a population of 3 million, across 3,000 square miles or something. So we can have patients traveling 4 hours to come to have an operation with us. And we've had massive problems, and the services are very poor for getting these patients in to specialist services to help them with address poor dentition and to fit them with dentures and so on and so forth. Real problems. There's hardly any services out there. So I think that's a key learning point from tonight, really. Scott, I wanted to ask you in terms of pregnancy, because often we'll operate on patients, follow them up for 2 years, discharge them to the GP. That's what most units do. And then just very rarely we will get a letter to our MDT, hopefully from the Ops and Gynae team advising us that a patient who's had a previous sleeve or bypass, wherever, is pregnant. Can you please advise on X, Y, and Z? Do you have any established sort of pathways or follow-up or alert systems in your unit to flag up patients who've fallen pregnant?
We don't have any established protocols or pathways, which is probably a weakness. I mean, I went on to the BOMSS website just to get the BOMSS guidelines, and there aren't specific BOMSS guidelines. I know that there's a list of sort of bits of advice and the grade associated with them, but it's probably an area that we do badly. The Kaiser Permanente, they make the point in this paper that since COVID, there's been so much movement towards virtual appointments, and how successful these telephonic sort of virtual phone follow-ups can work for people. And doing these papers, it sort of stimulated, as Andy was talking about, with some other aspects. It makes you think about your own practice to some extent, and it probably is something that we need to be a bit more robust in how we deal with, and putting some more robust information together. I mean, we tell people that because of the word around BOMSS, 12 to 18 months before you get pregnant, and you need your blood measuring during each trimester. But there's actually very little real evidence for any of this. I think my gut feeling is that a period of time, the massive weight loss time, is not a great time to repair hernias. It's not a great time to have babies. There's lots of things you mustn't do for the first year or so.
Yeah.
But there's not much evidence about what the best way is. We try and steer people towards regular follow-up and appropriate nutritional screening in each trimester. And that's probably, at the moment, that's the limit of it.
So I think in most services, the services that I've come across in my training and so on, I think that it's very similar, that the provision to this patient group who do fall pregnant post-op is very limited. You're lucky if you find out about them, if they're flagged up to you. Sometimes patients will call the bariatric coordinator with us to advise that they've fallen pregnant. What do I need to do? Then, then the system is set up for the nurses to call, they get a dietitian review and so on. But I think it is definitely probably in the UK services that are lacking. And I haven't managed to read the Kaiser Permanente paper yet, but I will do, because the link was sent in the invitation email that BOMSS put out yesterday. So I'll forward that to our dietitians definitely for us. But were there any important take-homes from the program that they ran that you took, Scott, that we should all be sort of implementing as standard of care? Because those absolute risk reductions are huge, absolutely huge.
I think it was more having the input was the impression I got. I mean, this is retrospective, so the patients are going through this system. So to eke out which aspect of it is the most important, this paper can't really do that. Some paper, they do put details about how pregnant people were at their first presentation to the nutritional clinic. There wasn't any statistical significance there, but some patients don't turn up till halfway through or 3/4 of the way through their pregnancy. So not everyone is getting regular follow-up. there is a deterioration in nutritional parameters mentioned in the paper. So they measure 5 parameters: hemoglobin, iron, B12, zinc, and stuff, I think it was, and they move away from the normal reference ranges during the pregnancy. They had a limited cohort of patients who had the baseline bloods at each stage of the trimester, but it does seem that there is less of a fall from the norms in the group who undergo the telephone follow-up or the follow-up clinics, telephone and face-to-face. So it does mitigate against some of the changes that occur, it would seem. Mm-hmm. And that may be in part why there are better nutritional, the outcome measurements are improved in the follow-up group.
Yeah, definitely. I guess if you go looking for something, you find it, you can do something about it, isn't it? As opposed to
they are empowered to modify medications, and that would seem quite important to me. They had protocol-driven medication modification for nutritional medication and certain illnesses, diabetes, hypertension, things like that, according to how the patients are progressing.
Fantastic paper. No, thank you very, very much for bringing this paper to the Journal Club. We've got a question here that if you can just answer in terms of what your centre do. Does your centre address contraception pre-op with patients? What do you say to your patients about advice about contraception pre-op?
I think Scott already touched on this a little earlier. We do discourage them, generally speaking, across the first 18 months. Perhaps even often I describe it as 24 months, actually. The New England paper out of Sweden from Martin Neovius's group, which is based in Stockholm, that was pretty high powered. And it suggested that there was definitely an excess risk in pregnancy in those who've had bariatric surgery. And it was particularly pronounced in that first 18 months. And that was both to maternal outcomes and neonatal outcomes. Pregnant and actually fetal outcomes. So I think it's absolutely crucial that we talk about this in the clinics, and it's one of the things that we try to reiterate at various multiple time points, because there's a few really important things that need to not be buried in the whole discussion. There are some things you can get away with, they might not retain detail about it, but I think this is an important one that we have a duty to be saying, a bit like if you're feeling worse, a few days after your operation, something's going wrong, you should be feeling good. Get in touch with us. Just because you're home doesn't mean we don't want to hear from you if anything changes. Catching people with things like this where actually, we probably do have something to add by getting dietitians involved early. And those relative risks, like you said, speak for themselves. If we have the potential to make even a portion of that difference, we've got to be doing it.
There's just the final question, hopefully for tonight, from Lisa. Were there any changes in early supplementation of vitamins and minerals between the groups? Scott, can you give a quick answer to that one? She hasn't had a chance to read the paper, so I hope I'm conveying the question correctly.
They don't talk about changes in supplementation. Okay. They talk about protocol-driven changes, but they don't talk about pregnancy per se driven changes.
Fantastic. All right. So just because we're out of time now, can I just thank you both again for a really, really fantastically run Journal Club, and thank you for changing the format slightly because I think we've learned a lot tonight and it's worked very nicely and ran beautifully. Okay. The next webinar that we will hold will be on the 26th of July, 2 weeks' time, and it will be delivered by Marco Adamo from UCL. He'll be talking about the SADIS procedure and hopefully telling us all we need to know about that. So hope you can all join us. So Andy, Scott, and the team at Swansea, thank you ever so much, and thank you all for joining us tonight.
Thanks very much, Sharif. Thanks for hosting.
Good night. Thank you.